I'm once again Mentor Ray, your fact check buddy. Now, I'd like to discuss with you the difference between Alzheimer's disease and Pick's disease, which is, okay, a type of frontotemporal dementia. Okay, so from being your mentor, I am now your fact check buddy. And before we get to start our discussion, let me shout out to one of our passers. Congratulations to Maria Lourdes Torres Quijano of the University of Perpetual Health System, okay, who is now a USRN, and she passed the New York Board of Nursing last July 19, 2021. If you want to be like them, our passers, join me in my 45 days Power Pack exclusive NCLEX RN test preparations review class starting September 11, 2021. Okay, so I also would like to ask you to join me in this mission to provide free NCLEX application and review to 100 nurses. To help achieve this, just watch and finish the ads in our videos. Thank you. So let's begin our discussion and differentiation of these two types of dementia. Now, when we say dementia, it's usually progressive and irreversible. So is it something that is expected with aging? No. Cognitive impairments are considered not part of healthy aging. So you're not expected to have Alzheimer's. You are not expected to also develop frontotemporal dementia or Pick's disease. So let me first begin with a functional concept. Unlike Alzheimer's disease, in Pick's disease, symptoms occur earlier. So the onset would usually be between the age of 40 to 50. Then behavioral problems occurs within those time. Then making sense of their words and that of others is difficult. So this is the difference. In Pick's disease, they have difficulty understanding their words and that of others, which may not occur until late in Alzheimer's disease. Now, in Pick's disease, there are no delusions and hallucinations. Unlike in Alzheimer's disease, they have delusions and hallucinations. Memory problems are not that much in Pick's disease. And in fact, their spatial orientation or their ability to recognize their environment is intact in Pick's disease. Unlike in Alzheimer's disease, they usually get lost in familiar places. In Pick's disease, that does not occur. Getting lost in familiar places does not occur in Pick's disease. Okay? Now, here are some concepts and functional concepts and questions related to Alzheimer's disease. Okay, now, another thing that we need to be focused on, if you are studying for the NCLEX at this point, would be your Alzheimer's disease, which is a form of dementia. Now, is it enough to just focus on Alzheimer's disease? I would advise you, no. Try to study Alzheimer's and try to study other forms of dementia, like, for example, frontotemporal dementia, like your Pick's disease. Okay, and then try to identify the similarities, the way that we did it for prostatitis and BPH, and the differences. So what is important, therefore, is that you know what Alzheimer's disease is. Okay, so the main problem in Alzheimer's disease would be the development of senile plaques. Okay, that could be associated with the presence of your amyloid. And this leads to the destruction of the neurons that secretes acetylcholine. So once acetylcholine is decreased, learning and memory also decrease. Now take note that your acetylcholine is responsible for preservation of memory. Okay, so let's pay particular attention to these functional concepts. First, a protein called amyloid beta is the hallmark of Alzheimer's disease. Okay, so which means it is the diagnostic marker for Alzheimer's disease. So genetic tests can help diagnose Alzheimer's disease because they have found a potential familial predisposition or genetic predisposition to Alzheimer's disease. Well, it could sometimes be genetic, or sometimes it could be that because the same family members stay in the same environment, then there could be an exposure to substances, like some studies identified aluminum that is accumulated in the brain. And if one family could be diagnosed, all members could be diagnosed with Alzheimer's disease. They could be using the same utensils, they could be staying in the same location where there's a high concentration of aluminum. So it needs more validation to say that it could be associated with environmental factors as well as genetic factors. However, genetic tests can help diagnose Alzheimer's disease. Memory loss is the key symptom of Alzheimer's disease, but this is very difficult to identify because most of us, would usually associate memory loss with normal aging. We think that this is expected when your patient is growing old. But remember this class, remember this functional concept. Cognitive deficits are not expected as you age. So it simply means you're not expected to forget things when you grow old. Although most of us would say, oh, I forgot my appointment. I'm getting old. That could be our personal belief. But for some, could be beginning signs of Alzheimer's disease. I'm not trying to frighten you, but what I'm trying to say is it is a possibility. Okay? Now, your Alzheimer's disease could begin with mild cognitive impairment. So the initial stage would be your MCI, mild cognitive impairment. And I created a code, also MCI, okay, which stands for memory changes. So frequent forgetfulness, cognitive impairments, okay? So they forget details of the conversation and they would say, you didn't tell me that, even if you told them about it. Impaired ability to recall details of conversation, recent events, or appointments. So loss of memory of recent events. That's your anterograde amnesia, okay? Or this could be inability to learn new things. You just taught them how to do something and then they immediately forget it. So they used to be fast learners and they eventually become slow learners. And sometimes we attribute this to aging. So mild cognitive impairment may not necessarily be noticeable, especially for those who are not trained to identify these kinds of things, okay? They think it's a normal part of aging, but it's not. These are all beginning signs of Alzheimer's disease. Now, mild dementia due to Alzheimer's disease is characterized by, okay, mild dementia. Okay, this is now your mild Alzheimer's disease. So you have the code mild. Memory loss of recent events, okay, or anterograde amnesia, increasing difficulty with problem solving or complex tasks and judgment. A common manifestation of this is that they will have difficulty balancing checkbooks. They are issuing and issuing and issuing checks, even if they no longer have money in the bank, okay? Now, there's also loss of previous functions, or there's reduced motivation, okay? Avolition, that's a medical term, social withdrawal, and aphasia. Aphasia is inability to find the right words to say, okay? That's expressive aphasia. They are unable to find the right words to say, or they have difficulty identifying the words, and sometimes they have difficulty understanding spoken words. So that's receptive aphasia, okay? Now, your aphasia does not just occur in Alzheimer's disease. It also occurs in frontotemporal dementia, okay? Because in frontotemporal dementia, the frontal lobe and, okay, including the Wernicke's area in the temporal area, okay, the Broca's area and the Wernicke's area are affected. And so the patient may also have expressive aphasia or Broca's motor speech aphasia and Wernicke's aphasia due to affectation or receptive aphasia due to affectation of the Wernicke's language area and the area of comprehension in the temporal lobe of the brain. Now, D, diminished ability to organize or they usually get lost, okay? And then they misplace belongings. Now, the difference of a patient with Alzheimer's disease to that of a patient with frontotemporal dementia or Pick's disease is that for patients with Alzheimer's disease, they get lost even in familiar environments. That's why when they are in the unit, we never ask them to wear shoes because they would think that they are going somewhere, and that increases wandering. So it's very important that when they are in the unit, we allow them to use slippers instead. Okay, for patients with frontotemporal dementia or Pick's disease, okay, their spatial orientation, meaning orientation as to space, orientation as to where they are, is usually intact. So they don't get lost in familiar environments. That's your Pick's disease or frontotemporal dementia. And those who usually get lost in familiar environment are those who are having Alzheimer's disease. So it's very important, since these are cognitive impairments, your priority should be to frequently reorient the patient. Okay? And sometimes they have a tendency to misplace their belongings. So you would see the car keys inside the fridge, or you would see their wallet, okay, inside the sink. So this could be common observations for patients with Alzheimer's dementia. Then moderate dementia due to Alzheimer's disease is characterized by moderate, okay? Moderate dementia, moderate, okay? What are these? Memory loss like confabulation, or they make up stories to fill in memory gaps. So since they have forgotten the details, they create stories to bridge their memory gap. Okay. Now, this is actually to protect their self-esteem. So we allow them to confabulate, allow the patient to do that. Now, they also have inability to recall personal history. They don't know who they are. They don't know where they're from, including their phone number. So it's very difficult, especially for patients with wandering. Now, they could also have outbursts of aggressive physical behavior. So they act out, and this could potentially lead to a violent reaction. So it's very important that we manage this and avoid agitating the patient. Deepening confusion. So they will become disoriented as to time, place, and person. So initially, they don't know what the time is. They don't know where they are. Then eventually, they are unable to recognize the nurse. So you always have to introduce yourself and tell them your role. And then this is the time when wandering occurs. So they walk and walk and walk until they go to and reach a specific place, and they don't know where they are. Okay. They would also have exaggerated or unfounded suspicions. They think that a family member is getting money from their bank account. They accuse their husband or wives of having affairs. And sometimes they have a tendency to believe that these are real. So it's very important for the nurse to know that this could be unfounded suspicions. Okay. Patients in the moderate stage of dementia love to repeat their favorite stories. So you would usually hear them talk about these stories over and over and over again every day. So they talk about their dog. They talk about how they used to be admired by a lot of people once again. And sometimes you would note that their stories would have different versions because they are having memory gaps. So they are just trying to confabulate to fill in the memory gaps. And then they would usually have agitation, which means they're having anxiety and restlessness late in the day, especially when the sun sets. So we call this your sundowning syndrome. So confusion that increases as the sun sets is what we call sundowning syndrome. Confusion that occurs as the sun rises in the morning is what we call your sunrise syndrome. So whether you're having sundown or sunrise syndrome, there will be disorientation. So it's very important. Your priority is to orient the patient. And then eventually they will have troubles with activities of daily living. So they will have bowel and bladder incontinence. So you have to assist them with bowel and bladder elimination. And then take note, they will also have difficulty choosing the right clothes for the weather. So sometimes they would wear sleeveless shirts during winter, and during summer, they would wear their leather jacket. So if you see an old patient wearing a leather jacket during summer, suspect Alzheimer's. But if you see a Filipino, not old, but wearing leather jacket during summertime, he's the action star in Philippine movies. Okay, and then they usually would experience visual and auditory hallucination. Now, this is very typical with patients with Alzheimer's disease. Look, they have exaggerated or unfounded suspicions, which could be a false belief. So it's a delusion. And they are also having hallucinations. So sometimes patients with Alzheimer's are given antipsychotics because they are having delusions and hallucinations. Okay. Next, severe dementia due to Alzheimer's disease is characterized by, take note, severe. They speak incoherently, speaks incoherently. So they themselves will not be able to understand what they're saying. Then they have extremely rigid muscles, which could be mistaken as symptoms of Parkinson's disease. The vocal cords get weaker, so their voice could be softer, and then excessive difficulty and loss of ability to swallow. So that makes them at risk for aspiration. And then eventually, in the severe stage, they require total assistance with bowel and bladder elimination and all activities of daily living. And then they experience a decline in physical abilities, like difficulty walking, they are unable to sit. So you will have to assist them regularly. So let's try answering a sample question. Which of the following interventions are appropriate for patients with Alzheimer's disease? Select all that apply, okay? Provide some choices every day, like asking the patient to choose from 2 outfits. Yes, this would enable them to exercise making a decision. Okay. However, you have to limit the choices to two. Do you want the black or the white? Do you want coffee with cream or without the cream? Not too much choice, because too much choice could agitate the patient because they get pressured for making a decision. Use clear one-step communication. Yes. Okay. Limit daytime naps. Yes. Otherwise, the sundown syndrome, that is agitation and confusion that occurs when the sun sets or at nighttime, could be aggravated if you don't limit daytime naps. So yes, we put a check. Turn off the TV at mealtime so they get focused. They don't get overloaded with stimulus. Yes. Consider buying identical outfits if preferred by the patient. Some patients, especially the elderly, would want the same set of shirts, the same set of shoes, the same set of underpants. Then you comply. Okay, because even patients with no Alzheimer's disease do that. I myself do that. I have several pairs of my favorite shirts because I love the fabric, and the same is true with them. Stick to bathing schedule even if it's met with resistance. Now take note of that some of them may forget that they have taken a bath. You would see them naked and they have taken a bath an hour ago. So you always have to assist them and say, if you feel dirty, I will have to assist you in washing yourself, or present reality, tell them that they have taken a bath an hour ago, but if they still feel the need to wash, then they can be assisted. But do not be too rigid with schedules, especially if it is met with resistance. So this is an X. Okay, so what are the drugs for clients with Alzheimer's disease? So you have your cholinesterase inhibitors. This drug prevent the destruction of acetylcholine. So in essence, it helps decrease the signs and symptoms. So you have your donepezil or Aricept, galantamine or Razidine, and rivastigmine or Exelon. You have the code ARE. So it will help improve agitation and depression. So the common side effects would be insomnia, nausea, anorexia, diarrhea, and a potential cardiac arrhythmia. That's why you have to check the heart rate. And then you have your memantine or Namenda. Okay, what is memantine? It's an NMDA antagonist, which simply means NMDA is N-methyl D-aspartate receptor antagonist. What does it do? So your memantine blocks glutamate. Okay, glutamate is found in clients in the seasoning that we do. Remember your MSG, in the Philippines, we call it vetchin, monosodium glutamate. Okay. Your glutamate is a substance that helps facilitate learning and memory. Okay. However, why do we need to block glutamate? Because when there is excess glutamate in the brain, it overexcites the nerve cells in the brain, the neurons. And when the nerve cells are overexcited, it could lead to rapid death. And that accounts for the loss of memory and the inability to learn new things. That's the reason why people were saying MSG, too much use of MSG could lead to Alzheimer's disease. Well, it could be a possibility. Now remember that your memantine is not a cure. It is given to slow the progression of symptoms or to treat the confusion. Okay, so the common side effects would be dizziness as well as confusion. Okay, so what is actually funny here is that memantine is used to slow down the symptoms, including confusion, but a common side effect could also be confusion. But sometimes, okay, the use of the medication outweighs those side effects. Okay, now let's talk about Pick's disease or your frontotemporal dementia. Let's begin with a functional concept. In frontotemporal dementia, the parts of the brain that are responsible for personality, behavior, and language shrink. So the frontal as well as the temporal parts of the brain are to undergo changes like atrophy. So there's shrinking or atrophy of the frontal and the temporal parts of the brain. Okay, so remember, this would actually require us now to recall the lobes of the brain. You have this in your NCLEX 311, page 233, for those of you who have the book. For those of you who don't have the book, if you may want to purchase one, get in touch with us through our email. So the frontal lobe is responsible, here's the frontal lobe, labeled A, is responsible for Broca's motor speech area, and that's going to be the left frontal lobe, okay? The language, okay? So that when the Broca's motor speech area is affected, the patient will have expressive aphasia. They are unable to find the right words to say. So if the frontal lobe is affected, patient will have expressive aphasia. It also is also responsible for motor functions and movements as well as memory, control of morals, emotions, judgment, personality. So the personality changes results from the affectation of the frontal lobe of the brain, and problem solving, impulse control, reasoning, and planning. So remember the 3 P's of the frontal lobe: personality, problem solving, planning. So the inability of the patient to plan would mean impairment of the frontal lobe. So therefore, if you are to be asked, when the patient experiences aphasia, which part of the brain is affected? You put an X on this part, labeled A. That's your frontal lobe. Next, the parietal lobe, that's labeled B, okay, is responsible for SPO, sensation of touch, temperature, pressure, and taste. And it's also responsible for pain interpretation and orientation. So if the patient becomes disoriented, which part of the brain is affected? Put an X here, labeled B. Okay. It's also responsible for your reading and arithmetic. Okay. Temporal lobe, you have here your Wernicke's language area, the area for comprehension. So you have auditory center or hearing, memory. That's why you would usually say, I can think of it. You're trying here, memory. You don't say, I can think about it, okay? And put on your finger to your occipital lobe. It should be, we usually point here, temporal lobe, okay? So memory, perception, and recognition, then Wernicke's language area. And then, so if you'll be asked which part of the brain is responsible for the symptoms of a patient with receptive aphasia, inability to understand spoken words, that's going to be Wernicke's aphasia. So the Wernicke's area, the temporal area here. So if it is expressive aphasia, put an X on this part, labeled A. Receptive aphasia, put an X on this part, labeled C. For occipital lobe, this is for visual processing, okay? So frontotemporal dementia occurs earlier than Alzheimer's disease. The risk for development of frontotemporal dementia increases with family history. In frontotemporal dementia, spatial orientation is intact, which means they are oriented to their surroundings. They do not get lost in familiar environments. Okay? Now, what are the manifestations of your frontotemporal dementia? Please do remember this, and please pay particular attention to how I describe this. So there are 3 categories: behavioral, speech and language, and movement disorders. If you will be asked which of these 3 categories would occur first, then we have behavioral. Remember our code: lapse, talk, trump. Okay? Okay, you can use this, but please do acknowledge that it came from our system. So lack of inhibition, judgment, and empathy. So these people, when they are angry, they have a tendency not to consider the feelings of other people. Okay? Frontotemporal dementia manifestation. They are judgmental. Okay? Their judgment is impaired. Okay? And sometimes you get to see them like walking naked because of the loss or lack of inhibition. And then apathy, no emotional expression. Then you would notice a decline in personal hygiene, emotional rigidity, that's considered personality changes, and then smacking lips and other compulsive behavior. They would usually also have pica, or they eat inedible objects, or they love to eat excessive sweets. Sometimes they eat even soil, or they eat plastics, okay? And sometimes they stuck on ice chips. That's pretty acceptable, but soil and plastics are not. So you have eating inedible objects as a common characteristic, okay, of patients with frontotemporal dementia or Pick's disease. Speech and language, they will have telegraphic speech, which are usually broken. They are having difficulty finding the right words to say. That's why their speech are broken, okay? It's like telegraphic speech, the speech of a preschooler. They will have aphasia, expressive aphasia due to frontal lobe affectation, because you have the Broca's motor speech area in the left frontal lobe area. Receptive aphasia, inability to understand spoken words, or Wernicke's aphasia. This is due to affectation of the temporal lobe. Loss of ability to know word meanings and knowledge of word meaning is lost. Okay, so they are groping for understanding words because they seem to have forgotten the meanings of words. Okay, for movement disorders, you would notice they have manifestations like patients with Parkinson's disease. So it's like patients with Lewy body disease, right? So they have tremors, rigidity, underactive or difficulty swallowing. That's why they are at risk for aspiration. They also have muscle weakness and mood swing. Sometimes they are irritable. And of course, they have poor coordination. So don't forget, once again, LAPS, talk, trump. Okay. So if they have behavioral, okay, problems, your nursing diagnosis could be impaired social interaction, okay, because of the behavioral problems. Now, for speech and language, okay, again, okay, your patient could have impaired social interaction because of their inability to find the right words to say and to understand spoken words. And then impaired physical mobility or risk for injury related to the movement disorders like incoordination or poor coordination and muscle weakness. Okay. Currently, antidepressants reduce the symptoms of frontotemporal dementia. Now, take note that these patients are given antidepressants, okay, in order to reduce the symptoms, not to manage the depression that comes with the disease. So let's try answering a sample questions. In the treatment of clients with frontotemporal dementia, the administration of antidepressants is made in order to, is it one, treat the accompanying depression? No, that doesn't occur. Reduce the behavioral symptoms? That could be a potentially correct answer. Decrease tremors and rigidity? No, that's not the rationale for the administration of antidepressants. Enhance physical mobility? No. So the best answer would be number 2. Reduce the behavioral symptoms. Okay. Which of the following are behavioral manifestations of frontotemporal brain syndrome or dementia? Okay. Now, when you are being asked behavioral manifestations, okay, so focus on that. Just identify the behavioral manifestations. Apathy, yes. Pica, yeah, eating of non-food substances or inedible substances. Loss of empathy, yes. Muscle weakness, this is a motor behavior. It's not a behavioral problem. In coordination, once again, this is a motor related symptoms or physical symptom, not related to behavioral symptoms. Okay. Next, in the treatment of clients with frontotemporal dementia, which of the following goals of care would be the highest priority of the nurse? Provide frequent orientation, prevent aspiration, prevent suicide, facilitate mobility. Now take note, in Alzheimer's disease, the priority would always be orientation because they are unable to recognize where they are. But that is not the case in clients with frontotemporal dementia. In frontotemporal dementia, spatial orientation, what is that? Spatial, is that the opposite of ordinary? Like special halo-halo in the Philippines? No. Spatial means orientation as to space, as to the area around you. In frontotemporal dementia, they are oriented as to space. So therefore, 1 is not the priority. So the best answer is 2, prevent aspiration because of their impaired swallowing. Okay. Okay, for those of you, once again, who may want to join me for an extended period of time, see you in my 45 days Power Pack exclusive NCLEX RN test preparations that begins on September 11, and we will have this for a limited slots only. Okay. So let's learn together. If you have any requests, send in your request to my email, mentor.raygapuz@gmail.com. So this is your mentor Ray saying a functional concept a day keeps your NCLEX RN fears away. So if you want to pass your NCLEX RN on your first try, join me, your mentor and your fact check buddy as we engage in an NCLEX learning session. So if you love this video, please don't forget to subscribe, share, and hit the like and bell notification buttons. Share it to your friends. If you share it to a minimum of 10 of your friends, You will pass the test with a minimum number of items of 75 and the shortest duration of time. If you want to request for the handouts related to what we have in this video, please send us an email. Hi, this time let me provide you with more sample questions related to the concept of BPH, or benign prostatic hypertrophy. So this is your mentor Ray, your fact check buddy. First, let's greet our passer. Congratulations to Mark Eugene de Peralta of the University of Northern Philippines, my fellow Ilocano, northern part of the country, who passed the NCLEX RN for the State Board of the Northern Mariana Islands Board of Nursing. That's July 10, 2021. Congratulations, Mark Eugene de Peralta. We are so proud of you. Okay, for those of you who want to be like them, join me in my 45 days Power Pack exclusive NCLEX RN test preparations class, which will start on September 11. To know more details, send us an email. So join us in this mission. Our goal is to provide free NCLEX RN application and review to 100 nurses. And to help us achieve this, just watch and finish the ads in our videos. Thank you. So here are more questions related to the concept of BPH. Let's try answering sample questions. Here we go. The nurse is about to insert a catheter to a client with benign prostatic hypertrophy. What is the primary reason for lubricating the catheter? Is it 1, to prevent infection, 2, to decrease spasm of the bladder orifice, 3, to reduce friction along the urethra, 4, to prevent formation of encrustation at the bladder sphincter? The best answer would be definitely to reduce friction along the urethra. Okay, in order that the patient will not have too much discomfort. Next, which of the following manifestations occur in benign prostatic hypertrophy? Let's begin. Difficulty starting the flow of urine, yes. This usually occurs because the enlarged prostate would press on the urethra, okay, resulting into difficulty starting the flow of urine. Frequent nighttime voiding or nocturia, this is expected in patients with benign prostatic hypertrophy, yes. Voiding at more frequent intervals, we call this frequency, yes, because they are unable to completely empty the bladder. That's why they void very, very frequently. Greater force of urinary stream, no. They have decreased force, okay, of urinary stream because of the obstruction in the urethra. And then decreased frequency of urination, they have increased frequency of urination, not decrease. Okay. Now, next, here's another question. Which of the following statements about finasteride are true? Select all that apply. Crush tablets should not be handheld by pregnant women. Yes, because it could be absorbed in the skin and may cause birth defects in pregnant women or women who are about to become pregnant. Okay, so we put a check on that. It is used for treatment of hair loss. Yes. Okay. It can cause erectile dysfunction in males. Yes, studies have shown that it could potentially cause that. It should not be taken with sildenafil. No, the one that should not be taken with sildenafil is your Viagra, because is your nitroglycerin, rather. Sildenafil is your Viagra, because combining sildenafil with nitroglycerin could cause fatal hypotension. Then breast lumps in male normally develops. No, the breast lumps may potentially indicate breast cancer in.
Now, let's talk about this condition. I'd like to share with you, class, you have to remember this. For whatever reason there is, your guess is as good as mine, okay? So let's talk about myasthenia gravis. Now, when you have the word asthenia, it simply means muscle weakness. So myasthenia gravis simply means there's muscle weakness. In essence, okay, you have to ask yourself what could have caused the myasthenia and what could be a common presenting manifestation. So the exact cause is unknown, but it's believed that it could be due to an autoimmune reaction that leads to a deficiency in acetylcholine receptor sites. Now take note that in myasthenia gravis, the area that is involved is your myoneural junction. It is the point at which The brain gives out the signals, and it's supposed to be transmitted by neurotransmitters like your acetylcholine, and it should be received by your acetylcholine receptor sites in the muscles. Now, what happens in myasthenia gravis is that the brain sends the signals, acetylcholine carries the signals, but you have a deficiency of the receptor sites. Therefore, since the muscles are not getting enough signals, they are not contracting, and so they have grown weak. That's the simple way of remembering it. And then, because they've grown weak, eventually it's easy for them to be pulled down by gravity. Hence, they have drooping of the eyelids, which could be unilateral or bilateral. This picture is from Creative Commons, okay? Now, myasthenia gravis involves deficiency of acetylcholine receptor sites. That's an important phrase for you to remember. Deficiency of acetylcholine receptor sites. Because if you just have deficiency of acetylcholine, then that could be associated with Alzheimer's disease, because acetylcholine is the neurotransmitter responsible for preservation of memory. So if you are deficient in acetylcholine, you're having Alzheimer's disease. But if your deficiency is going to be on acetylcholine receptor sites, then that's going to be myasthenia gravis. Okay? In myasthenia gravis, muscle weakness leads to double vision and drooping of the eyelids. These are the first signs and symptoms. So the muscle weakness actually begins on the face going down. So that's called descending paralysis. Okay? Your Guillain-Barré is manifested by ascending paralysis from the legs going up, and sometimes it's occurring at the same time from the neck going down, from the legs going up. So you have mixed type of muscle weakness. That's in Guillain-Barré, not in myasthenia. Myasthenia, it begins on the face, double vision, drooping eyelids, difficulties with speech, and absence gag reflex. You know for a fact that your gag reflex, okay, is related to the functions of cranial nerve 9 and 10, your glossopharyngeal nerve, and your vagus nerve. And if you have problems with cranial nerves 9 and 10, eventually your patient would exhibit hoarseness, okay? So they would also have difficulties with swallowing and breathing because of the weakness of the muscles for breathing, and eventually weakness of the arms and legs. So the patient may no longer be able to stand. And this descending paralysis will occur in just a matter of minutes or hours. So it could begin, okay, to develop slowly, and then eventually it could happen and progress, okay, and then it would affect the entire body, specifically the voluntary muscles, okay? So in myasthenia gravis, it's common in both men or above 60 and women below 40. So let's try answering a simple question. Which of the following observations in a client who is seeking consult for muscle weakness are associated with myasthenia gravis? A smile that looks like a snarl. What is a snarl? Snarls like when you are so angry and you want to growl. That's a snarl. So yes, because of the muscle weakness of that occurs on the face. Nasal speech, yes. Swallowed water comes out of the nose because of their difficulty of swallowing. So the swallowing muscles are not coordinated. Yes, that could occur. History of eating honey. You know, botulinum toxicity is the one that occurs after eating honey, because a common source of botulinum toxin would be your honey. And that's the reason why honey should never be given to children below 12 months of age. So a common manifestation of botulism would be facial muscle paralysis, similar to myasthenia. What differentiates it is that you would know that it's due to your botulinum toxin when there's a history of intake of home canned products like honey. So this is an X. Weakness that started from the legs moving up. So this is Guillain-Barré syndrome. Weakness that started from the legs going up in a matter of minutes and hours, that's Guillain-Barré syndrome. Difficulty holding up the head with difficulty breathing, yes. This could be associated with myasthenia gravis. So, in most cases of myasthenia gravis, diplopia and ptosis are the first signs and symptoms. So, the factors that worsen myasthenia gravis would be menstrual period, infection, surgery and stress, fatigue, illness, and treatment with beta blockers, quinidine, phenytoin, and antibiotics. Now, remember, you have here the word stress. So sometimes you would expect that the muscle weakness of a patient with myasthenia gravis could be triggered by a stressful event like going to the dentist. The same stressful event that triggers a Addisonian crisis. So you would know that a patient with myasthenia gravis or Addisonian crisis is able to anticipate the effect of the event to their health if they take medications before they expose themselves to a stressful event. Because whether we like it or not, we have to visit our dentist at least twice a year. Okay? So in that case, you have to prepare yourself for putting yourself under a stressful situation. So diagnosis of myasthenia gravis involves neuro checks. Okay? When you say neuro checks, remember the code RMCBS. So R would be reflexes, M would be muscle tone and muscle strength, CBS would be coordination, balance, and the sense of sight and sense of touch. Okay? IcePack test, on the other hand, when the eyelids are drooping, the doctor would usually place an ice pack for 1 to 2 minutes and then it's removed, and then the doctor will evaluate if there's an improvement or not. Because if there's not going to be an improvement, that could mean that they will need to perform further tests to rule out myasthenia gravis. Now, your EMG, pay particular attention to this, involves inserting a fine wire or a very, very thin needle into the muscles. And sometimes the patient is asked to alternately contract or relax the muscles, and the activity of the muscles is recorded on a screen. Okay? So if the patient would ask if this is going to be painful, you just have to tell them that there's just going to be a slight sting or stung that they will feel. And then the patient will have to undergo your CT scan and your MRI to rule out other conditions. Okay? And of course, to check on whether they are having pulmonary problems, they will have to perform the pulmonary function test. Okay, now what are the medications that are given to patients with myasthenia gravis? So first, in myasthenia gravis, you have a deficiency in acetylcholine receptor sites. Therefore, you have to ensure that the patient's acetylcholine is normal. And so we give medications that will prevent the destruction of acetylcholine, and these are called cholinesterase inhibitors. An example would be pyridostigmine. Common side effect includes excessive salivation, sweating, diarrhea, and nausea. Now, the purpose of your cholinesterase inhibitors is to improve muscle strength and contraction. Now, corticosteroids, example would be prednisone, could be given to limit antibody production. Now, this could lead to weight gain and eventually thinning of the bones that leads to fracture. So it's very, very important for you to note that if the patient's taking steroids orally, you have to administer it with meals to prevent GI irritation. Okay, and of course, since your corticosteroids could potentially cause immunosuppression of the patient, your priority nursing diagnosis should be risk for infection. Then immunosuppressants like azathioprine or cyclosporine. Now remember, cyclosporine should not be given with grapefruit juice because your grapefruit juice would decrease the absorption of the drug. Okay, it is given to alter the immune response of the patient, and taking immunosuppressants may lead to increased infection, liver, and kidney damage. So you always have to check the liver function tests and the kidney function test. Last but not the least would be your intravenous immunoglobulins and monoclonal antibodies. Now, your immunoglobulins are given to the patient to provide normal antibodies. Your monoclonal antibodies like rituximab or eculizumab, these are usually given to strengthen the body's response to the potential autoimmune reaction that develops when myasthenia gravis results. Therefore, you have to remember that your IV immune globulin may cause fluid retention, dizziness, and headache, and this has to be explained to the patient. So once again, these are the 5 classification of the drugs. You have cholinesterase inhibitors, corticosteroids, immunosuppressants, IV immune globulins, and of course your monoclonal antibodies. Now, if the patient with myasthenia gravis would not improve with traditional treatment like administration of medications, then they will have to perform thymectomy. So thymectomy involves removal of the thymus gland. So the thymus gland actually produces antibodies. And you know for a fact that myasthenia gravis could be associated with an autoimmune reaction. So therefore, it's the body's defenses attacking its own. So to prevent that from happening, to stop that from happening, then you have to remove the organ that produces antibodies. And that's going to be your thymus gland. Now, there's a surgery that's called robot-assisted thymectomy, which involves making small incisions on the side of the chest to remove the thymus gland. Okay, so you just have to explain this to the patient that robot-assisted thymectomy has an advantage of, okay, faster recovery, so lesser hospitalization or confinement, and of course, definitely it leads to lesser hospital bills. Okay. So let's try answering a simple question. Which of the following interventions should the RN implement in providing home care for a client with myasthenia gravis? Select all that apply. Now remember that the main problem in myasthenia gravis is muscle weakness. And the more you move your muscles, the more weak they become. So since we have the same muscles that we use for talking and eating, avoid lengthy phone calls before meals. Yes. Because if you do that before meals, eventually the patient would be at high risk for aspiration, because the muscles that they will use for talking are the same muscles that they use for eating. Okay, so we put a check. Install grab bars, yes. Okay, remember you have weakness of the muscles. Use electric toothbrush. Now, what the hell? Why do we need the electric toothbrush? Remember, you have muscle weakness in clients with myasthenia gravis. You have to conserve as much energy as you can. So use all sorts of power-generated equipment like electronic or electric toothbrush to conserve muscle strength. So we put a check. Avoid watching TV. Oh, it's not really a contraindication. Some patients, when they have drooping of the eyelids, what they do is that they put on a patch on one eye and still use the other eye to watch the TV. And then when the eye gets tired, specifically the eye muscles, then they just transfer the patch to the other side and use the other eye for watching TV. So watching TV is not contraindicated. You can ask your patient to continue doing so. Engage in one-time full-day shopping. What is appropriate for them is going to be short, frequent, okay, strenuous activities. So one whole day of shopping is just too much for a patient with myasthenia gravis who's having muscle weakness. So this is not appropriate. Have frequent small meals and avoid raw fruits and vegetables. Why would there be a need to avoid raw fruits and vegetables? They require energy, okay, for mastication, because these foods are raw, and therefore patient will need to exert more effort, and that could worsen weakness. Okay, so yes, those raw fruits and vegetables needs to be avoided, so we put a check. Okay, now what are the common complications of patients with myasthenia gravis? Remember this. You could either have myasthenic crisis and cholinergic crisis, but whether you're having myasthenic crisis or cholinergic crisis, remember, the common manifestation, the general common manifestation would be muscle weakness. So you wouldn't know whether the muscle weakness that has become severe in a patient with myasthenia gravis is due to myasthenic crisis or cholinergic crisis if you don't perform a specific test. So let's talk about myasthenic crisis and differentiate it from cholinergic crisis. Here we go. Here's a functional concept. Muscle weakness may indicate a complication of myasthenia gravis. Okay, so if you have a patient with myasthenia gravis who exhibits weakness that has become severe, note for the cause. It could either be due to too little medication. So if the patient's not receiving enough medication, so which means their acetylcholine could further decrease and the muscles will not react, therefore the muscles would become weak. Okay, and this is what we term myasthenic crisis. Myasthenic crisis is manifested by respiratory failure, so your priority would be ineffective breathing pattern. So always check the patient's respiratory rate. Bronchorrhea, excessive mucus production, and then increased salivation, and the heart rate would usually decrease because of muscarinic activation of the muscarinic receptors, which could lead to the reduction of heart rate, meaning bradycardia. Okay? So, in this case, to reverse the reaction, you have to administer neostigmine, because neostigmine is the treatment that is given to a client with myasthenia gravis. And since myasthenic crisis is due to too little medication, then you'll just have to treat it with the medication that's supposed to be given to the patient. Okay, now, what about when the patient has too much medication? You have an excess medication. Once again, the patient would be having weakness. That's why this is what is difficult, myasthenic and cholinergic crisis. So whether you have too little medication or too much medication, there's going to be muscle weakness. So how would you know that it's cholinergic crisis? When, take a look at the manifestation, there's respiratory failure, which also occurs in myasthenic crisis, bronchorrhea, also occurs in myasthenic crisis. Increased salivation, also similar to myasthenic crisis, but look at the heart rate here. Initially, the patient will have tachycardia, and then it progresses to bradycardia. Why is that so? The tachycardia is due to the stimulation of the nicotinic receptors, which would trigger the parasympathetic and the sympathetic nervous system, triggering now tachycardia. Then eventually, due to the muscarinic receptor stimulation, the patient will also have bradycardia. So, if it's going to be muscle weakness with bradycardia, think about myasthenic crisis, too little medication. If it's going to be tachycardia that progresses to bradycardia with muscle weakness, think about cholinergic crisis, which is due to too much medication. But take note, even if a patient is having muscle weakness in a client with cholinergic crisis, they still exhibit positive deep tendon reflex, which could be 2+ or more. Okay? Now, your cholinergic crisis is managed through the administration of the antidote of neostigmine, and that is your atropine sulfate or one of your oxims. It's called pralidoxim. Okay? So administer atropine and, it's not or, atropine and pralidoxim. Now, if the patient just presents with muscle weakness and you have yet to classify whether it's due to myasthenic crisis or cholinergic crisis, then you perform what's called tensilon test. Tensilon test entails the use of endrophonium hydrochloride, a short-acting, cholinesterase inhibitor, which means your tensilon increases the level of your acetylcholine. So, the disadvantage of tensilon, that's why it cannot be used as a form of treatment, is that it has a short duration of action. So, the action fades after 5 minutes. So, if you use this as treatment, you'll have to ask the patient to take it every 5 minutes. That's not a very good routine to do, taking medications every 5 minutes. So, this is just used for diagnostic purposes. So, if the patient comes in with muscle weakness, you give tensilon. Remember, tensilon acts like your neostigmine. So if tensilon relieves muscle weakness, then the patient's having myasthenic crisis. Because what you have in myasthenic crisis is too little medication. You're adding tensilon, which is a form of medication. So if tensilon relieves muscle weakness, that's myasthenic crisis. However, if tensilon worsens muscle weakness, that's cholinergic crisis. Because remember, cholinergic crisis is due to too much medication. So muscle weakness that is relieved by tensilon is due to myasthenic crisis. Muscle weakness that is worsened by tensilon is due to cholinergic crisis. Now, this is another thing that I made to highlight this thing. You would notice that on your left-hand side, myasthenic crisis, which is due to too little medication, is represented by a pale orange color. Just to remind you, it's due to too little medication. And your cholinergic crisis on your right-hand side is actually written in a red font. That's just to highlight that it's due to too much or over medication of the patient. Clever way to do it. Simple but clever just for you guys. That's how much I love you. I would exert additional effort just for you to remember this. Okay? So whether your patient is having myasthenic crisis or cholinergic crisis, the priority would always be respiration, because in both conditions your patient would be having respiratory failure, and since there's increased salivation, they are also both at risk for aspiration. Okay, so remember, here's a functional concept. Muscle weakness with bradycardia may indicate myasthenic crisis in a client with myasthenia gravis, and it has to be managed with the administration of neostigmine. On the other hand, muscle weakness with tachycardia that progresses to bradycardia may indicate cholinergic crisis in a client with myasthenia gravis and should be managed with your atropine and pralidoxime. Okay, so remember, in cholinergic crisis, sludge syndrome occurs. Sludge is actually an acronym for a group of symptoms like salivation, lacrimation, urinary incontinence, diarrhea, GI upset, and emesis. Now, even if this could be present, it is not something that's present in all cases of cholinergic crisis. So sometimes it could only be 3 of these, 4 of these, 5. Okay, but in some conditions, all of this could be present. So it's called sludge syndrome. Once again, salivation, lacrimation, urinary incontinence, diarrhea, GI upset, and emesis. Okay, way to go. So here's a feedback from one of our participants, our viewers, Catherine, and she says, no dull moments with your lecture, Sir. You explained it in simple terms and easy to understand. Thank you for sharing your talent. May God bless you for your generosity and kindness. And of course, somebody also said, thank you so much, Dr. My heartfelt gratitude for all of this, especially receiving the blessing of having a new lease on life. Thank you so much, dear colleagues. And this is the impetus that has kept me going and helping out nurses achieve their great American dreams. That is to practice in the US through my YouTube channel. So now let's have some sample questions on myasthenia gravis. Okay, here we go. Which of the following medications will the RN anticipate to administer in a client with cholinergic crisis? We know for a fact that cholinergic crisis is due to over medication. Too much medication was given to the patient, so we have to give an antidote. And the antidote for neostigmine would be atropine. So the answer would be letter C. Now, diazepam can worsen the muscle weakness in a client with myasthenia gravis. However, if your patient has multiple sclerosis, diazepam will lessen the rigidity. So if you'll be asked on the test what drug is contraindicated in myasthenia gravis but could be given in multiple sclerosis, that's gonna be diazepam. And remember, you do not give diazepam with herbal remedies kava or valerian, because giving them in combination could lead to respiratory depression. And diazepam is incompatible with any drug, so you always administer it separately. So which of the following clients is most likely suffering from myasthenic crisis? Now we know for a fact that myasthenic crisis is due to under medication. So all we have to do is to give neostigmine or pyridostigmine. But the question is asking about manifestations. Is it 1, 40-year-old with muscle weakness, drooling, and a heart rate of 56 beats per minute? 45-year-old client with muscle weakness with a heart rate that is either abnormally high or low, 60-year-old client with ascending muscle weakness, or 62-year-old with weakness of one leg, one hand, the face, and the tongue. Number 4, a 62-year-old with weakness of one leg, one hand, the face, and the tongue is having amyotrophic lateral sclerosis. That is a disease of the upper and the lower motor neurons that usually begins with one extremity and then progresses to the other parts of the body. Now, number 3, a 60-year-old with ascending muscle paralysis, this is Guillain-Barré syndrome. Okay. Number 2, when you have muscle weakness with a heart rate that's either high or low, so tachycardia to bradycardia, this is your cholinergic crisis. But when you have muscle weakness with bradycardia, then that's your myasthenic crisis. So the answer is number 1. Way to go! Now, 3. Which of the following activities may not be beneficial to a client with myasthenia gravis before meal times? I told you they make use of the same muscles for eating and for talking. So definitely 1, talking over the phone for more than 2 hours is not beneficial. All the rest could be allowed. Next, in a client with myasthenia gravis, which of the following nursing diagnosis is the highest priority? So they could have muscle weakness of the muscles used for breathing. So your highest priority should be number 3, number 2, ineffective breathing pattern. And which of the following clients is the priority of the nurse for assessment of risk for aspiration? Now, always remember that risk for aspiration occurs when there is muscle weakness. However, what if all options includes muscle weakness? Okay, so think about the complications. There's usually increased salivation in clients with myasthenic and cholinergic crisis. So you have to look for that. And the answer is number 3. Why? Because a client exhibiting bradycardia and salivation could be having myasthenic crisis. And in clients in myasthenic crisis, they will have increased salivation, so they are at risk for aspiration. The client in option 1 is exhibiting muscle weakness. That's expected. In option 2, ptosis is expected in myasthenia gravis. Option 3, myasthenia gravis having diplopia and weakness. Once again, these are expected. So look for the salivation, which could be excessive in clients who are having myasthenic crisis. Okay, now let's talk about GERD. Gastroesophageal reflux disease is the #1 gastrointestinal problem among Americans. Okay, now this is how the normal stomach looks like. Okay, so this is from Creative Commons also. Okay, so you have your lower esophageal sphincter that prevents the backflow of stomach contents into the esophagus. Okay, and the stomach content after 2 to 3 hours moves on to your small intestines, the duodenum, the jejunum, and then the ileum. Now, what happens when your lower esophageal sphincter relaxes? So there's going to be a backflow of stomach acids, and this could lead to a sensation of like a burning sensation near the heart. That's why it's called a heartburn. Now, if this happens continuously, eventually the lower esophageal area becomes eroded, and that leads to a condition known as Barrett's esophagus. And Barrett's esophagus increases the risk for the development of cancer. Okay, so here's a functional concept. GERD is acid reflux that occurs regularly. A mild form occurs twice a week, whereas a moderate to severe form occurs once a week. So GERD is manifested by, remember, GERD, gassy or burning sensation on the chest, extra lumpy throat sensation, or sometimes they would have a throaty feel, or they would feel discomfort in their throats, regurgitation of food, and difficulty swallowing. So GERD. Risk factors to GERD, remember the code HUPS, okay, which means this could occur with hiatal hernia, obesity, so definitely you ask a patient to lose weight, pregnancy, because the pregnant uterus could push on the stomach, and then eventually causing stomach contents to regurgitate upwards into the lower esophagus, and then stomach emptying that is delayed, and of course in clients with scleroderma, okay, which could be an autoimmune condition. Now, factors that aggravate GERD includes here's your code, SIL, smoking, eating fatty foods. Why is that so? Because fat delays emptying of the stomach. So if you have high fat in your stomach, eventually the acid stays there a little longer, and when backflow occurs, then heartburn results. And then alcohol, which relaxes the lower esophageal sphincter, and of course aspirin, and large meal or late night eating. So those of you who love to go on midnight snacking, you will aggravate the symptoms of GERD. So nighttime acid reflux may lead to chronic cough, laryngitis, asthma, and disturbed sleep. Now, eventually, the patient's voice could become hoarse because of the esophageal reflux. So the diagnosis for GERD involves your upper endoscopy, a pH probe, specifically of the reflux. If it's acidic, it's coming from the stomach, esophageal manometry, and the upper GI X-ray, including your barium swallow. Okay? So what are the medications that are given for GERD clients? You have antacids like Milanta to neutralize stomach acids. You have your H2 receptor blockers like cimetidine and famotidine to reduce acid production for longer relief. However, intake of H2 receptor blockers may lead to vitamin B12 deficiency, leading to pernicious anemia. Your proton pump inhibitors or PPI, lansoprazole or omeprazole, esomeprazole or omeprazole. These medications are used to block acid production and heal the esophagus. Once again, like your H2 receptor blockers, it could also lead to vitamin B12 deficiency, and because of the thinning of the bone, could lead to hip fracture. And of course, your skeletal muscle relaxant, your baclofen, sometimes is sold under the name Lioresal, okay, which is given to decrease reflux and strengthen the lower esophageal sphincter. So take note that your baclofen may cause nausea or fatigue. Now, in clients with GERD, there's a surgical intervention called laparoscopic fundoplication, in which the lower part of the stomach is attached to the lower esophageal sphincter to reinforce it, to strengthen it. So that would, in essence, create constricting effect on the lower esophageal sphincter, preventing now the backflow of your stomach contents. So remember, GERD is manifested by the code GERD, HOPS, always remember, GERD, HOPS, seal, clad. Okay? GERD, HOPS, seal, clad. Now, sometimes the problem is we remember the code, but we forget what they mean. Okay, so you have to make sure that you remember the code and remember what I mean. Okay, so let's try answering a simple question. So which of the following statements about gastroesophageal reflux disease is true? Weight loss can help improve the symptoms. Yes. Sitting upright after meals decreases heartburn. Yes. So it's appropriate for them to sit upright, read a book after meals. Okay, that would help. So reading books after meal times could help in patients with GERD. Not just reading books, reading magazines or reading newspapers, whatever there is that would keep them upright. Okay? GERD may disrupt sleep. Yes. Smoking may help relieve symptoms. No. It could worsen the symptoms. It does not progress to cancer. Remember we said a while back that GERD could lead to Barrett's esophagus, which could potentially lead to cancer. So we put an X. Small frequent meals may help decrease the symptoms. Yes.